I want to welcome everyone to the June 9th V3 implementation call. Thanks so much for taking time out of your day to be with us. These meetings are recorded. They are shared on our website and on our YouTube channel for you to share with other team members or to review if there's a topic that you want to go back on. Chris also does a fabulous job of time stamping. So if there's just one topic that you want to go back and watch, you don't have to scroll through the whole thing, and you can target that topic with the timestamp that Chris has put in the comments on the videos that are loaded to the YouTube channel. We do consider these meetings conversation. Your questions, input, feedback are so valuable to this process, not only to the NEMSIS team, but also to other stakeholders. Learning from each other is the best way to make progress in this industry, and we really appreciate your contributions, your comments, and your questions. It's so very helpful. All right, first up on the agenda, we're going to turn a few minutes over to Laurel Baeder for a maintenance update.
Hi, everyone. Good morning or afternoon. So for our maintenance this month, which would be next week on Tuesday and Wednesday, that's the 15th and 16th of June, we will be doing some server patching, and we don't expect there to be any extensive downtimes, but individual services may be in and out during the day on Tuesday. That would include things like report portal, our cubes, our Tableau server, our website, possibly submissions. But again, we don't expect any lengthy outages, just restarting things as we patch. So that's coming up next week. If anyone has any questions about maintenance this month or maintenance moving forward, please feel free to ask now, or you're always welcome to drop me an email. My email address is on the NEMSIS website. And I think that's all I have today. Thanks, everyone.
Any questions for Laurel? All right. Next on the agenda, we've got Ben Fisher, and he's going to talk for just a minute about time zones and the UTC offsets.
Thanks. So something that we kind of encountered as we were cleaning the research data set for this year, and we just like to remind everyone to make sure that agencies are reporting time zone offset correctly with all of their times. So the way the standard looks, time should be reported in local time with a UTC offset or GMT with an offset of 0. Just what we don't want is local time with a UTC offset of 0. So it's 9:05 a.m. in Utah, which is UTC -6. So that would be an okay time to report 9:05 with an offset of -6. Or you could report UTC, right now it's 3:05 in the UK with a UTC offset of 0. Just don't report 9:05 with a UTC offset of 0. If you guys have any questions, I'm happy to try and answer them, or Laurel as well. But that was just something we encountered in a couple kind of edge cases, and it can cause some weirdness with calculating elapsed time. So we just wanted to remind, vendors, if you could help agencies with that, and then states as you're looking at time data, if you see any of that, to bring it to the agency's attention. All right, back to you, Julianne.
Thanks, Ben. Are there any questions for Ben on that topic? Okay. Next on the agenda, we have Neil Milan and John Beckett with us this morning from the ET3 Enclave. We appreciate you gentlemen being with us on these calls to help answer questions and make sure our stakeholders are aware of what's going on with ET3. We will turn the time over to you.
Thanks, Julia. If you could let me go ahead and share my screen real quick.
Yep, you should be able to take host.
Okay, thanks. All right. Just real briefly, I just wanted to report on some onboarding as well as data submission activities. So we've got some good counts coming in. This is just a graphic here in the middle that shows you the first column is all the historical data count that we've got coming in, so that this is what we've been able to capture in our database, right around 4 million. So we've got quite a bit of data there from a historical standpoint. And then each one of the columns going to the right, from left to right, represent a month. So this is each month's worth of data. So you can see it's kind of consistent between 350K and 400K in some cases of data that we're receiving on a consistent basis. This is representing roughly around 134 plus submitters. And a submitter would be either a vendor or participant who's, again, using our API to send in the data. In terms of onboarding counts, we've got about 20 remaining that we're working with right now to get them onboarded. The different issues they're having vary. Sometimes it's dealing with some of the technical issues that they're having on their submission side, sometimes with their vendor, sometimes it's just getting established with a vendor. So we are working closely with them so that we can get them onboarded. In terms of some of the issues, I wanted to just touch on a couple things. One is the participant data that's coming in. We found about 22 participant submissions that came in and were subsequently dropped. This roughly was around 350K of ePCR records, and they're primarily dropped because of the de-agency field values. So if you guys recall, there is a de-agency 01 and 02 that we require that you have the right state ID agency ID values that are captured. And so there is a crosswalk that we've implemented that if it doesn't match what's in our crosswalk, we're gonna drop those records. What that means is we're not gonna ask you necessarily to resubmit those records, but we do need to reconcile with you to make sure that the right values are being submitted to us. So look for an email sometime in the near future. We're gonna send out and reach out to you, whether vendor is sending us the records or the participant. And we want to make sure that, again, those values are correct. So just wanted to point that out. The second issue we found is that in some cases, there are multiple PCRs being sent in one transmission. And what we're finding is duplicate records that are coming in. So you might see where someone has sent an ePCR submission to us, and either they're dupes in that submission, or they may later in the day send the same transmission to us as well. And again, they're duplicate to what was sent to us before. So we're gonna, again, take a look at where the submissions are coming from and reach out to you and just, again, see if we can, get a little bit more consistency in terms of how those records should be sent. Couple other updates just real quick, and then I'm gonna end. There is an effort going on to prepare for NEMSIS 3.5. In terms of timeline, we're targeting the fall of 2021. So our development teams are currently meeting with the NEMSIS folks to prepare for that and get those updates in our system so that we can support 3.5 sometime this fall. The other update I'd like to make is that encourage your participants, or if they've given the vendors the ability, encourage them to register for the ET3 application. This is different than getting a security key, and it's a different application whereby you want to register as a participant role. And the purpose of it is to do monitoring and data management, and as well as doing data reporting. So we get questions sometimes, hey, we just sent you a load of data, wondering if you got it. Well, if you're in the ET3 application as a participant, you can actually go in and take a look within a couple of days to see if that data has been not only received, but also put into the database. So I just want to encourage registering for that. And it does require for you to go ahead and cancel the security key request role that you have and go ahead and register for the ET3 application. So we're, again, asking folks to only maintain one role at a time. And so if you have two individuals who are playing different roles in the organization, certainly one can be the security key requester, the other can be the ET3 application requester participant role. All right, I'm going to go ahead and pause there. And Neil is on, I believe. And if Neil, if you have any other updates you'd like to share.
Sure. Let me pause real quick if there's any questions before I. Okay. Hearing none, let me go on video here real quick and apologize for clearing my throat while not on mute. First of all, thank you to the TAC for providing me a quick minute to make an announcement to the larger community. This will be my last V3 implementation call because I will be leaving ET3, the ET3 project, as of the end of this week. So a few things are in order. First, a big thank you to Mr. Eric Chaney and the NHTSA Office of EMS, and to Dr. Clay Mann and the NEMSIS TAC for really bringing me in, and just the amazing collaboration that we've had. It's cross agencies, it's also cross public and private sector, and I think Mr. Chaney will say it's been smooth, and I echo his statement about that. It's also been an incredible experience for me as well. I also want to extend great thanks to the vendor community as well as the EMS community at large for your patience, your flexibility, and honestly your candor and the feedback in ways that ET3 could serve you well, and what we could build to make your life easier, and just really some awesome feedback on how we can just get a better product out of all of this. So again, huge thank you. It's been an incredible over a year that we've been working on this. In terms of housekeeping, the second thing I'd like to say is that while I am leaving, Mr. John Beckett will be continuing to be the main point of contact for ET3 on the technical piece, as he usually does at these calls, and through the numerous emails and calls that we've had to work with you to move on data submissions for ET3 and just a lot of the technical troubleshooting we've been doing. While my role kind of on more of the programmatic side, the replacement has not come in yet. Don't quite have a timeline on that, but what I can say, if there's questions largely on the ET3 model, kind of program or requirements, those kinds of parts of the model, Brenda Staffen, who will be familiar to many of you, will be serving as that bridge role before my replacement comes in. She brings a wealth of knowledge and experience as well on the actual EMS side of the house, and I cannot think of anybody better who would serve as that bridge before the full-time replacement comes in. So I think with that, my closing point is just that while I can't predict the future, all I will say is that I will definitely be eagerly watching, reading, and listening on news or anything I can get to see what kind of groundbreaking work this community is going to be doing in the years to come. So it's a bit of a bittersweet time to be stepping out of it, but I have full confidence that this community will continue to really just do some amazing work and just show the fruit of this collaboration that crosses all sectors of especially the healthcare space, but just in general. So thank you so much.
Yeah, Neil, this is Clay. I just want to step up real quickly and just thank you for your service to this community. I have to tell you, many folks on this call know that understanding NEMSIS, getting a feel for how it works, why it works, the pieces of it, and what makes it really kind of probably the most impressive kind of exchange of healthcare data in the country. I've just been so impressed at your ability to kind of dig into that. And I think for this industry, we've had kind of stops and starts of CMS folks willing to kind of take a hard look at at pre-hospital medical care. Neil, just a great thank you to you for digging in so deeply into this, for staying so focused on this project and making it work. I really appreciate your efforts.
Are there any questions for Neil and John while we have them? Okay. Next on our agenda is a conversation with Michael Redlener and Sheree Murphy on NEMSQA. Michael and Sheree, do either one of you want to share your screen?
Yes, Julianne, thank you very much. I will
Okay.
I'll share my screen if I have the chance. And it looks like I'm able, so let me just see if I can do that. Are you seeing my presenter view?
We're seeing presenter view,
Okay,
and now we're seeing slideshow.
great. Well, I really appreciate the opportunity to come here today. I'm here with Sheree Murphy, who's the Executive Director of the National EMS Quality Alliance. I am the President of the Board of the National EMS Quality Alliance, and I just want to thank Dr. Clay Mann, Eric Chaney, and Josh Legler for inviting us here to have the opportunity to connect with so many of the folks we interact with on a daily basis, but in this forum. What we would like to do is really just kind of open a conversation about the National EMS Quality Alliance, give a little bit of an introduction in this format. Many of you probably know about NEMSQA and the work that we do, but we wanted to take some time to talk about what we do, our relationship with NEMSIS, the partnership that we've got on the national level, and how we think we all should interact together, and what our goals are, what our mission is, and how we think that you all play a part in that mission. So we just start off with the basic mission and vision here that you're reading on the screen. And the basic idea is that we want to improve patient outcomes through quality measures for EMS and health systems of care. And a lot of what we do really is accomplished through the NEMSIS data set and the system that we have all come to know and love. And we'll talk a little bit about that relationship. Both Sheree and I have no financial disclosures. I do represent the National Association of EMS Physicians on the board of NEMSQA. Sheree, do you want to take a minute to introduce yourself?
Sure. My name is Sheree Murphy. I have a 15-year history in working in quality improvement and systems of care, primarily focused on cardiovascular and stroke, and I'm excited to come over into the EMS space and lend my experience in this particular setting.
Great, thank you. Again, as an introduction for myself, my name is Michael Redlener. I am an emergency and EMS physician in New York City with the Mount Sinai Health System. I've been thinking about quality improvement and quality measures for over a decade now. And I'm interested in the way that we can really improve care for our patients and understand how we can succeed as an industry and in improving care for patients. And so looking at evidence-based measures and understanding how to implement them in the community is really something that I feel passionately about. And that's what really brings me to this discussion. Right, so this is a little bit about how we're going to structure it. I really want this to be a discussion, not a one-way street. I'm going to ask for your input on some of the topics that we're going to discuss, which probably be about a 10-minute long presentation. And Clay, you can stop me if I get too long-winded. Many of you may be familiar, but NEMSQA is really, it's an organization that seeks to gather a large group of EMS representatives from across the organizations. We represent a broad swath of the EMS community in terms of the organizational structure. There's a lot of innovation and leadership has come from the folks who are involved in the National EMS Quality Alliance. We seek to really develop quality measures with a very strong NQF-based format for measure development. So we are very much in line with kind of a national measure development process. And again, it's a collaborative space where we can develop measures. So the founding steering committee are these organizations. And we have a broad array of stakeholders who have been involved with the development of the organization. Many of you know EMS Compass, but and the foundations of NEMSQA are really in EMS Compass and the work that EMS Compass did around building measures for EMS. There was a kind of a break in the work that EMS Compass did, and the National Highway Transportation Safety Administration really was interested in making sure that quality measures were out there for the EMS community. And this is a little bit of our timeline. And over the last few years, we focused on like putting out the reviewed and respecified measures for EMS Compass. And we've been working on additional measures since that time. But I think what I want to focus on today is just really talking a little bit about the existing measures, which are we're calling the national quality measures. They're the EMS Compass measures that have been respecified and put out there again. I'm going to kind of focus on the NEMSQA based website, but just know that NEMSIS, which has been a great partner to NEMSQA over the time that we've been around, they have built out quite a dashboard and an API related to these measures within the NEMSIS world as well. So we'll discuss that in just a moment. But for those of you who are familiar, you know that there's 11 measures. They all have technical guidance on the website that can be accessed by all of the technical specialists, both here and whoever would like to utilize them for purposes of quality improvement and measurement within either within the electronic medical record basis or independently of it. We have also not only the technical aspects of these measures identified, but also the reason and rationale why we use them. And I think that this is important for this community to understand that we've worked directly with NEMSIS to really think very broadly about how you build these measures. In the life cycle of a measure, there's a lot of iteration around what specifically we include in a measure in terms of the technical specifications of it. And this is something that we would look to this group really to kind of identify ways to improve the way we take measures from the electronic space and make them something that is feasible and something that is meaningful for EMS organizations. So just for those of you who are familiar with measure development, there is there is a kind of a broad approach, and this diagram is really to share and to show kind of the steps in the process that we go through to select the types of measures that we are interested in developing and putting out to the EMS community. So identification, prioritization of quality measures that will be available to the EMS community. And then we need to make sure that we're doing evidence-based work, that the specifications work well and that work within the setting that you all function in, and then we test them within the systems that exist. And so I'm going to talk a little bit about kind of what we did with the EMS compass measures, and then a little bit more about what NEMSIS, how NEMSIS has helped us to kind of make sure that we're getting this right in terms of the data and the data elements. So we took EMS compass measures, we put them through our development model here, and we've come out with the 11 measures that you saw on the earlier slide. And then, in terms of the way that we have worked with NEMSIS, and Clay and Josh have been really great partners in making sure that all of this, all of the data and the measure specifications measure definitions are solid and right on for how they can be implemented on an agency level, on a system level. But we, Clay and Josh have been partners at every level of this, really, but have made sure to be involved with how we think about this process in general. So we've used data in testing measures. We've used it in learning about how to develop our measures more specifically. But it's really been a great partnership as we have moved kind of through this realm of making and designing measures that work for EMS communities. So I'm going to pause here a bit just to say that there's a bidirectional relationship between NEMSQA and NEMSIS, and then ideally what we imagine is really that NEMSIS has already kind of provided this kind of expert guidance and leadership around how to make quality measures real in the EMS space. NEMSQA's role is really around thinking about what are the clinical things that matter for EMS patient care, and how do we build and how do we think about the data that we collect, and how can that influence what goes into NEMSIS is something that we've talked about and thought about in our conversations between NEMSIS and NEMSQA. But the third part of that is really around how does it work for you all? How do we, if we're interested in thinking about how to develop and implement quality measures for EMS on the ground, we really need to involve this group in that discussion. And so part of the reason why I'm here is really to talk with you to kind of understand what the challenges are for you, and to kind of make a bid to have you think about how you're going to incorporate and include the NEMSQA measures in your products, in your states, wherever it may be relevant. So I'm going to kind of pause there. I have some other minor points of discussion, but I'd love to hear your input around these topics. And Sheree, or if Clay, you have any specific items that you'd like to highlight, I'd love to hear from you.
Yeah, Michael, great presentation. Perhaps I'll just briefly just remind both the states and the vendors the products that we attempt to make available to support NEMSQA. What a great opportunity to have a organization of experts that are really passionate about standardizing our assessment of performance kind of on a national level. That's incredible. We've had, of course, the API. Josh did the heavy lifting on that. It's really a product whereby vendor products can call into that API and receive very agency-specific benchmarking data on these performance measures that can then be brought back into the local software and provided to our clinicians for them to look at their performance compared to like agencies across the country. Would love to hear from the vendors or the states about uptake of that API, if there are issues associated with uptake, if there are reasons, both political or technical, as to why that may have not been as successful as you had hoped. I'd love to hear about that, how we could improve that. And as Michael mentioned, we have the Tableau dashboard that's been available publicly so that an EMS agency could describe their structure of their agency and then look at that national performance data just at a public level. We have just finished a state level dashboard that allows the state data manager to be able to go in and isolate a specific agency within their state and provide a PDF report from them on any of the NEMSQA measures that can be measured with national data. And I'll just mention NHTSA is really supportive of this process and has asked us in this next funding year to see if we can define some process whereby Tableau reports could actually be served to actual agencies, so they could actually themselves track their own performance, right, compared to national benchmarks. So we'll be working on this hard as well over this next year. Would love to hear from folks about issues with uptake. Is there anything that on the clinical side, Michael's team, or on the technical side, us trying to serve that data, how can we make this more useful?
Hi, this is, oh, sorry, go ahead.
No, you first.
Oh, thank you. Hi, this is Joe Cartier from the state of New Hampshire. So the first question, I'm gonna plead my own ignorance here in the rules that you're using. I saw you put up some technical guidance for how you gain those measures, and they look effectively like the validation rules for our schematron that we're using. Is there somewhere that we could get those rules if we wanted to incorporate them into our schematron here at the state?
So, Joe, maybe I'll take a stab at that. There's the NEMSQA website, NEMSQA.org. There should be the full package of kind of the measure specifications that are available and for use and implementation. I'm not sure about the technical pieces of how do you implement it myself, but from what I understand from our measure development experts and our technical folks, that those are just available for you to use and input. And I'm not sure how you actually do it, but I understand that it's available.
Yeah, I'm looking at that right now. Thank you. Yeah, that looks great. That is precisely what I was looking for. And I guess the second thing I was going to put out there is just a recommendation, which you may already be doing as part of your research process, is it may also be valuable to look at the schematrons that are put out by states to see what they're measuring locally for sort of outcomes with their patients. That's just a general comment.
That's a great point. And I think that there's all of this is like all about bidirectionality and making sure that that we can align as much as possible. Hopefully, what we hope is that the states would benefit from the rigor in which the measures that come out of NEMSQA are done with, and that when there's an idea that comes from the states that is something that you find valuable, that is something that you'd want to highlight, we do envision a process in which we kind of have recommendations coming to NEMSQA about specifying these measures to be national measures. And so I would definitely encourage or invite anyone to share their state measures, what they look like, initiate a conversation with us to talk about how to take a good idea that's evidence-based and has served to improve patient outcomes, that how could that become a more standardized national measure. And that's really what we hope to be, really a clearinghouse for these clinically important type of measures.
Michael, I'll just piggyback on that. You said it well. We are currently undergoing a process of identifying those measures that might exist out there to see what might be good to move forward to national measures. So I appreciate that suggestion as a place to go to identify what those measures might be.
Great. Thank you very much. And it'll be beneficial to the states too for us to know, we identify our measures with some rigor, but obviously comparing it nationally would be a huge benefit for us. So thank you for that.
Yeah, this is Amber over in Colorado. We use the NEMSQA measures quite often, and we try to produce them in, just basic Excel percentages in a report that we send to all of our regional coordinators. And I think first, the conversation we just had about involving the state data managers would definitely be beneficial, because I know there's a lot of great work being done. So maybe some presence at the DMC meetings, the Data Managers Council would be helpful, just to get some input from all the state data managers. And then the other thing I just, and I guess I don't really know the best way to do this, but a lot of the issues we run into, and I'm thinking particularly of the lights and sirens transport measure, we look at that all the time, but we still struggle with data completeness. And so I wonder if there's an opportunity to have a little bit of focus on the actual data quality and helping states, agencies, for us, our regions are heavily involved in just identifying where there might be data quality or completeness issues first, and then digging into some of these metrics, because that's what we're finding with the additional transport mode descriptors. Is just simply a lot of our agencies never fill that out. They're putting, the null values in there, and that's why their percentages are so low. So we spend a lot of time then digging into the specific data elements and showing the frequency of each response, and that's why we're seeing kind of the results that we're seeing. But we've had to do that with most of the measures. So I wonder if there's an opportunity there to help educate folks through, some sort of presentation on data quality.
Amber, it's good to hear from you. And I definitely agree that the data, the kind of data quality and data completeness is an important issue. I think it's definitely something that we can address. I think, there's this balance of trying to get good quality data and going forward with measurement. And so, we've kind of taken this tack of let's go forward with kind of putting out these measures and thinking about, like kind of engaging all of our stakeholders around getting that message out and getting those ideas of, we need to measure to the community and to the people who are doing the work. And then I think that's a conversation that definitely comes along with that. And they probably need to happen in parallel. And I think we'd be happy to talk about those types of issues as well.
Yeah, and I think, that's a good point. Maybe, and this is going to sound interesting, but maybe that's my role, right? And that's my region's role. And that's my, state CQI coordinator's role, is to focus on the data quality so that we can get to the point that we can measure and compare at a national level. So I think that actually could be a good division of labor. I think I'm just sharing that's been our biggest hurdle right now, is really just getting the data in a good enough fashion that we can even start to look at it.
Yeah, no, I think it's important. Again, this is one of these kind of continuing projects that I know you all work on and focus on. So we'd love to support it in whatever way we can, but probably not our primary focus.
Yeah, Amber and Michael, this is Clay. Great comments, Amber and Joe. Hey, Josh, I just wanted to bring you in here. I know you've been really the person who's carried the weight in regards to make sure that kind of the technical description using NEMSIS data for these NEMSQA measures are kind of standardized. Have we looked at the relationship of these measures with the national schematron file? Does that make sense? I know we have lots of rules in the national schematron file, and I just wonder if we've just with an emphasis on the NEMSQA measures ever looked at those rules with that in mind.
I can't recall if we've specifically looked at them. So that would be a good review, and that, there's just a handful of NEMSQA measures using national elements. So it certainly wouldn't take us long to do a quick look through the national schematron rules and see if they're supportive of the, the data elements that are needed for these measures.
Yeah. So that's a good idea. Something that we could potentially do that may help states just with data quality to just make that review and see if we're missing something that might be an easy win.
Yeah, and I'll also mention in work I've done with states, generally we've developed data quality measures in tandem with the NEMSQA measures. So for example, if we're looking at the no lights and sirens during response or during transport, I'll take that as an example, we might see that 50% of records had that value recorded, that they went no lights and sirens on their transport. But we will partner that or pair that with a data quality measure where we see that 60% of records even had that element recorded at all. So that means out of 10 PCRs, 6 of them had a value. And of those 6, 5 of them said no lights and sirens. Well, that's great. 5 out of 6 went no lights and sirens. It's terrible when you look at it, it's 5 out of 10 went no lights and sirens, right? But the difference between the 6 and the 10 is the data quality piece. And so when we report both at the same time, we get a little more, I guess, interpretable understanding of where the performance actually is. And maybe we need to focus on data quality just as much as we need to focus on the actual reduction in lights and sirens use, and so you kind of tackle both together.
And Josh, I would piggyback on what you're saying, because I think that when you dig into a lot of quality problems, right, it's hard to tease apart the quality of the data and documentation and the actual work that's being done. Sometimes you don't have a problem. You just have a documentation issue and a problem. So I think getting to that point where you're addressing both at the same time is really, I think what you're describing seems like a great solution. If I can do a segue into a project that NEMSQA is working on that, I'll just make a quick pitch. This project is something that we feel strongly about, and we're working with partners across EMS to think about how do we reduce the lights and sirens usage across both response and transport to the hospital. And we're in the process of kind of developing and forming our ideas about how do we use these quality measures that we're building in to NEMSIS and NEMSQA, hopefully is being taken up into the community. But we are looking for both organizations and agencies that, one, who have done work on reducing lights and sirens and can, serve as partners for organizations that haven't addressed or implemented a project to reduce lights and sirens. Because as the evidence shows, reducing lights and sirens use also reduces accidents and injuries and death for patients and EMS providers. So this is my just 2-second pitch to see if there's anybody out there who'd be interested in joining a project like this as a participant agency or as a partner in this project. It's something that you can reach out to Sheree because it's kind of it crosses this threshold. This is the reason why we collect data. It's the reason why we do quality measures, and we really want to engage with agencies and organizations around the country to make improvements, implement improvements in how we provide care to our patients. So honestly, I think that we've covered most of what we wanted to cover. If there's any other questions or comments, I'm happy to answer. And if there are, but please feel free to reach out to both of us to ask any questions. But we really like to work together to get these measures out into the community. So whatever you can do to implement the work, either through the API with NEMSIS or independently, we'd love to see these measures out there in the communities. I think you're a big partner in making that happen. So thanks again for the time and the opportunity to come to speak here. There's lots of opportunities to partner with us, and we look forward to hearing from you. Thank you again, Clay and Josh and Eric for the opportunity to come today.
Hey,
We're happy to come back whenever we want, whenever you invite us.
I have one last quick question in terms of getting involved with NEMSQA. I think NEMSQA was considering kind of a new model of different ways to be a quote unquote member or partner of NEMSQA. Has that been rolled out?
Josh, thanks for bringing that up. We're in the process of rolling it out. So we are hoping to engage this community in all levels of partnership, whether it's individual agency or on the corporate level. But we would love to have, and there's a few partnerships in between. Sheree, maybe you can speak to that for a minute.
Sure. I was going to say, I put my email in the chat, so anyone who does have any suggestions or questions or want some more information in how to become involved more formally, certainly reach out and email me. But yes, as Michael said, we've approved an update which provides more flexibility around organizational membership, and will also include options for agency and individual membership as well. So we have approved it and are in the process of rolling it out, but certainly feel free to reach out if you're interested in more specific details until we get that posted on the website.
Thank you, Michael and Sheree. Any other questions for them while we have them? All right. Next on our agenda, Monet is going to talk to us about some questions on de-agency values. Monet, did you wanted to share your screen, didn't you?
Yes.
Okay.
Hello, everyone. How are you? I hope you're all doing well today. It's so great to see so many familiar faces. Can you see my screen okay, Julianne?
Yep.
All right. So I have been asked to make a presentation about this, and this is a question that I get often. So I'm just going to go ahead and go through de-agency 01, 02, and 04. First of all, I'd like to say thank you so much for everyone who has helped to submit the data from the 50 states and territories, 4.3 million records from 12,000 agencies. That's a lot of data. I wanted to let you know that on a weekly basis, I am looking at a version of the state level data submissions, but it's in a national report. And so this dashboard basically provides indicators of concerns and opportunities to create national best practices. So this week, we have about 2.8% failed submissions. And that represented about 96,000 failed files, failed PCRs for the last week. Now, this is a state, there are state-specific dashboards, so each state has an opportunity to log in and look at their reports. Now, at the state level, I'm seeing a lot of great things happening. All this green represents awesome data from your EMS clinicians, clean data. But then I'm looking at these red bars, and I'm looking to identify the concerns, provide the information back to the state managers, offer assistance, and share the best practices that we see from other states. Now, this is the most common question. Why is de-agency 01, 02, and 04 impacting the state submissions at the national level? So for the DIM files, there's one reason. There's an XML schematron validation error, and this might be that it's just not complete or it's missing. And EMS files fail for two reasons: the XML schema or schematron validation error, or non-matching 01, 02, and 04. So if we look at the data dictionary element definitions, we see that for D agency 01 is the unique ID assigned to the EMS agency, which is associated with all state licensure numbers and information. D agency 02 is the state assigned provider number of the responding agency. Most of the time, I've seen 90% that these numbers are exactly the same. However, there may be a reason for them to be different. And then D agency 04 is the EMS agency state, and that's the state or territory which assigned that EMS agency number. All right, moving into some of the examples of the mismatches. So you can see here in the DIM information, we have an agency 1234, the D agency 02 is 1234, and then I have a made up state for number 52 AP. But in the PCR, that DIM agency DIM 02 is inconsistent with what is indicated in the DIM file. Here's another example. We have, 4321 assigned for D agency 01, then D agency 02 is 1243, but then we have also inconsistency in the D agency 04, which is the state. And then the third example, let's talk about the EMS transport across state lines. So the values must match for NEMSIS to match the agency DIM file to the PCR. So here's a perfect example of what we're looking for with regard to the match. Now, I've had a couple of conversations with state managers as well as vendor products or agencies, and have asked this question about mutual aid. And the consensus is that if the state has licensed that agency, that the PCR belongs to that state. So even if you're crossing state lines, we need all of the information in the DIM files and the PCRs to be consistent. And this is where we're seeing a lot of those mismatches in those failed submissions. So here's the ask of this state level data submission dashboard is provided for each state manager. And we actually push this dashboard out to each manager on a weekly basis. So what we would like for you to do is look at this report. If your failed submission rate is greater than 1%, then look at the EMS agency detail tab for any missing agency demographic information, and then either correct the DIM or correct the PCR, and then resubmit those records. So that's all I have. The last thing I wanted to say is the why. We've talked a lot about the value of the data. The first thing we're doing is we're trying to create reports, the state level dashboards that are useful for each state manager. That quality data trickles down to the national reports, such as, just any type of reports in publications that could be published as it relates to improving public health. And then we also have vendor level dashboards where we're providing feedback about the quality of the submissions. That's all I have. If you have any questions, please feel free to contact us or send us an email to the nemsis@hsc.utah.edu mailbox. And one other thing I would like to offer is I have worked with some individual agency levels to populate the information, and we have had great success doing that. So if you need any additional assistance reaching out to your agencies to get the information completed, I'm sure we can free up some time to do that as well. Thank you so much. If you have any questions, let me know, and I will turn it back over to you, Julianne.
All right, thank you. Any questions for Monet? All right. Next on our agenda is an update on our data use agreement project for 3.5 and public health surveillance. Eric, do you want to take some time and talk about that? I think we've got Eric on by phone. Clay, do you want to introduce that topic while Eric's getting connected?
Yeah, sure. Happy to do that. Yes, well, I'll just mention we've been working with the states for a number of years actually to determine how we might be able to make some modifications to the standard data use agreement we have with states that might allow for some public health surveillance geomapping opportunities that still protect the confidentiality of the providers, the patients, and the designated hospitals who receive our patients, and also really focusing just on looking at those public health issues, not on performance or treatment protocols or medications given or anything like that. To ensure that we're kind of doing this well and in a way that is legally sound, Eric has asked that we engage with Page, Wolfberg, and Worth, a legal team in the EMS industry that are helping us to redefine a new data use agreement that would incorporate this idea and still provide strong protections to states in regards to the topics I've just discussed. So we're in the process that we have a contract now with Page, Wolfberg, and Worth. We're in the process of defining what we'd like to have spelled out in this document. We'll bring this document back to the state data managers, and so that they can take a look at how we're phrasing this up. The data managers group actually provided some great feedback during last year's V3 implementation meeting last summer in regards to this topic. So much of that conversation has been built into this document. So more to come on that.
Any questions on that topic? All right. Next on the agenda is a conversation about body cameras in use. Clay and Eric, do you want to tag team that one? I think Eric's trying to get connected, so that might take.
Okay. Okay, happy to do that. I'll share my screen just real quickly. Can you see my screen? Hi, Julianne. Yep. Okay, great. Yeah, I'll just introduce this topic. Eric also has asked Page, Wolfberg, and Worth to help us develop a document that kind of describes the legal considerations that are associated with the use of body-worn cameras. We're kind of towards the end of cleaning up a great draft that's been provided by Ryan at PWW. I imagine this document will be released this month. And so for vendors and for states, if you're looking for some guidance that you can provide to agencies regarding this topic, this should be available very soon.
All right. Next on the agenda, any questions on body cameras? Has anybody been getting questions from their agencies on policies for that? Okay. Next on the agenda, data submission lag, addressing timely submission from states. Clay, that one's yours again.
Yeah, thank you. Yeah, thank you very much. And so I'll share my screen again. On the last DMC call, we made this document available that what we were trying to do was actually compare state regulations or recommendations to agencies as to how quickly they'd like to see a PCR completed and submitted to the state. Kind of compared that to how long it was taking for us to receive that record based on the time that the EMS agency indicated on a record that they were back in service until the time that it arrived in our repository here at the national level. we made this available to states, and actually Jay from Wyoming, they have one of the most condensed time periods for the completion of a record. They'd like to have it done within 2 hours of being back in service. He looked at this report and found that his median delay was 10 days. When we kind of dug into this, we realized that what this report included was resubmissions, right? So if someone goes back and corrects a name or adds insurance information, then our system, of course, looks at the time that they were back in service to when we now receive the new updated record, rather than just relying on when the record was first sent to us, right? Which is probably the important issue that I think states are kind of thinking about now after the pandemic. You know, the value of having the data in quickly to look at offload times at hospitals or just the rate of ILI within areas. So we've come up with a mechanism just this last week in our technical conversations with our IT team as to how to tighten this up so that our estimates aren't so weighted down by resubmission. So we'll be redoing this chart and making this available to states, and so they can just kind of take a look at what's happening in regards to when their data is available at the national level. And of course, we have been providing it to the CDC and to HHS and other folks associated with the pandemic. I think it's been incredibly valuable. Right now, it's as of last week, and it varies by week, of course, it takes about a month, about 700 hours for us to receive about 75% of the records that occur on any given day. And of course, that includes some agencies that are sending back legacy data, you know, and other things that kind of mar that picture. And that's why we're wanting to get more accurate information to states. So we can just kind of, as a nation, kind of look at how long we want to kind of hold on to the data. States have great reasons why they perhaps have asked their vendors to hold on to records for a certain period of time before storing them or passing them on to state registries or the national registry. Just want to make sure that we kind of understand the process for record overwrite and things like that, and just ensure that all the states feel comfortable with the submission lag that they're seeing in their state. So we'll tighten up this report, and we'll get that back out probably in the next couple of weeks.
Hey, Clay, this is Amber. This is a question that's come up a lot in our state. So I'm wondering if there's a way that you could share your approach to how you're going to calculate these things. And if, you know, I want to be able to mirror it so that you come up with the same answer that I come up with. And then I can share that with my regions and my agencies so that we can know specifically which agencies might be submitting, you know, have longer submission times and which ones are shorter. Would that be possible?
You bet, Amber. Yeah, we can do that. We'll write that up and make that available with the new calculations. Yeah, thank you.
Any other questions or comments on that? All right. Next on the agenda is items from the Office of EMS. I think Eric was having some technical difficulty. Did we get you back, Eric? Okay. I don't think we've overcome that technical hurdle. Let's go to open forum. Are there any questions, comments from the audience?
Hey, Julianne, Andrew Hawthorne from ESO.
Hi, Andrew.
Hi. I just had a quick suggestion. It seems that there is a thirst for overdose data, and there seems to be no uniformity in how folks are requesting that data. I think it'd be helpful if the TAC were to put together some sort of, call it a position paper, white paper guide for best practices, and maybe perhaps have a forum of vendors and states that are requesting that data and kind of come together. And what are you trying to measure? What are you trying to record, and then kind of put together a guide for, you know, recommended practices for getting that? Is it custom elements? Is it something else, that type of thing. I know that we're finding that across states, everyone has a different, they seem to be wanting to measure the same thing, but they have a different way they want to receive the data. And I think it would be beneficial for both the vendors and the states if there was some sort of guide to have some sort of consistency and perhaps best practices for getting that data.
Are you
Just a suggestion.
Are you finding that these requests are coming from state level stakeholders? Are they coming from reporters or medical community? What's that overall requester audience?
Generally speaking, we get it from, thank you, Amber. All of the above is really the answer. Okay. We get it from our customers. Sometimes there's a team of people who are looking at opioid overdoses. Sometimes it's a medical director. Sometimes it's a researcher. Sometimes it's a state data manager, and I suspect they're reporting into some public health authority that is looking at this information. So,
are the requests that you're seeing state specific, or how are they trying to zero in on geographical locations?
They're state specific.
Okay.
Yeah, Andrew, that's a great idea. Josh, do you want to speak a little bit to the work we've been trying to do on this very topic with the State and Territorial Epidemiologists Council, and then also the defined concept document? Do you want to speak a little bit to that, Josh?
Yeah, we've been working with the Council for State and Territorial Epidemiologists to come up with a case definition for an opioid overdose. So it's saying, how would you find the patient care reports where there was probably a patient affected by opioids? And so we have a case definition that will be published by the NEMSIS TAC shortly, like in the next few weeks, probably. In fact, I think I gave an update on those case definitions last call. And then the Council for State and Territorial Epidemiologists is working on finalizing their document that they'll publish as well. There is one main difference between the NEMSIS case definition and their document, and that is that they will recommend the use of parsing the patient care report narrative for certain keywords. And we're not including that in the NEMSIS case definition for a couple of reasons. One is you can't run that on national data, so you get different results on national and local data. And number two is to promote the use of the structured data elements within NEMSIS and kind of promote an increase in data quality in that direction. But yeah, that's one thing that's being worked on that could probably be of some help here.
Good. Well, and it's things that go beyond patient care, perhaps, or kind of maybe are on the fringe. Let's use it for example. A leave behind kit for Narcan, right? How does that get documented? Because sometimes they want to record that, right? Or let's use, did a law enforcement officer give Narcan prior to arrival, right? They want to collect that information, and some are doing that in a custom element, and some are probably looking through the patient care report data and finding that, right? And it varies from state to state of what they're looking for and how they're looking for it, right? And if there was some sort of recommended best practices for finding this data, perhaps that's beneficial to all.
Yeah, Andrew, great thoughts. We'll certainly put out those the document on our side, and then the one that's coming out from the Council of State and Territorial Epidemiologists may provide some standardization. But even when you look at those, Andrew, maybe we should come back and revisit this, because when you look at that, it still looks like it's not as tight as perhaps what we could do with this great relationship we have within this industry, where maybe we could just try to provide some educational components that limit the number of ICD-10 codes, for example, that are used to define this type of an event. So that would be valuable. And it looks like Peter from Oregon mentioned that they have a query that they're validating. Lots of states have these queries, and they may vary, as Andrew mentioned, significantly. So there's some room here to do some great work. Peter, we'd love to see here at the TAC what you guys are doing in Oregon. That could be helpful for us. So
And
Any
Clay,
oth-
I'm happy to talk further about it if you want.
Oh yeah,
offline.
please.
You're welcome to reach out to me if you like.
Okay, great, Peter. Thank you. Thank you.
Well, that one was Andrew. So.
Okay, sorry. Sorry, I'm not
Peter
seeing.
too.
Okay,
Yes.
okay. Thank you, Andrew. Yeah, I appreciate it.
I wonder, so Clay puts out a EMS by the numbers weekly report that shows the trending of overdose and naloxone related activations. Is a trend line over time something that would be helpful on a state level, or like you were mentioning, Andrew, some of those more specific aspects of the response characteristics, what's being used to document the additional aspects of that patient care? Is a trend line helpful, like what we've been doing on a national level for the overdoses? Let me see if I can pull that up.
Yeah, Julianne, and of course, the limitation to that is that we don't include kind of the parsing of the narrative, and many states claim that they can do a much better job in sensitivity by including that, and of course we don't get that at the national level. Yeah, so how can we better capture these people in a coordinated way, right? So we do a broad look at F11 codes and T40 codes. So either opioid related disorders or poisoning by opioids, right? But that's far from the type of definition I think that the Council of State and Territorial Epidemiologists are going to mention. So, and Caitlin does a great job of mentioning the SNOMED code that's associated with kind of leaving educational materials behind for naloxone. So, yeah, there's some great work to do here, Andrew. Let's talk. We'll talk to Eric and see if there's something more we can do here. Yeah, something needs to be done, and you'll notice that when you see what comes out from the Council of State and Territorial Epidemiologists. Wow, just a barrage of codes that have to be aggregated across the country that are all used to kind of measure the same thing. Gosh, we've got to come to some tighter definition. So that's a great comment.
And as Andrew noted, finding the opioid cases is only one piece of it here. The other piece is this stuff like doing the leave behind kits and naloxone education and that kind of stuff. And clearly there could be a wrong way to do that, right? Someone could just go ahead and record naloxone in medications given. And we could have all kinds of a mess in the data, when in reality what they did is they left naloxone there, but they didn't actually administer it at that moment. And that's a big difference. And so some guidance could be helpful.
Yeah, great discussion.
Mm-hmm. Thank you. That's it's a great topic to address. Any other questions, comments, concerns?
This is Sheree at NEMSQA. I don't want to come between people and their lunch and possibly getting out of this call early, but I wonder if maybe we could go back to Clay's question that we kind of moved on from to make sure that we got through the rest of your agenda about vendor uptake of the API or programming the measures, who currently uses it or has the measures programmed in their software, and what the experience has been, I think would be helpful. And maybe if we don't, have this conversation on today's call, we have it on another call, because we're really excited about the measures and new standardized national measures, but we want to make sure that we make it easy to do QI. So I think, understanding, I really liked Clay's question to really understand how we can do this better. So I don't know if you have any thoughts on whether I could take some comments from anyone on their uptake of the API or the existing measures now, or if you want to table that to another call.
Yeah, let's spend just a couple of quick minutes on that, Sheree, if we could. vendors or states out there, do you have some comments in regards to uptake or use of the API? How many folks are actually calling into that API to add that data to their software products, and so that their agencies can view benchmark data? Yeah, thank you, Joe, from New Hampshire. They're not using it. Other folks using it? Yeah, Peter asked if states can pull the data directly from the API. The products can. We make it available for the vendor products to do it. Could a state do that? That's a great question, Peter. Let us come back with a more complete discussion of this to kind of delve into these questions. That's a great thought.
Yeah, this is Josh. The API is publicly accessible through web services requests. So there's no account needed or anything. So Peter, yeah, you could, if you've got some programming resources available, you could program up a web service client that would hit that API and grab the data.
Yeah, thanks, Josh.
The silence makes me think that vendors perhaps don't. I'd just be curious if any, why folks don't, just so that we can, make this more easily accessible, relevant, and get that out there to the agencies. Or people just want to go eat lunch.
It's a great topic to come back to. Oh, go ahead, whoever started.
That's all right. I was just going to say, this is Joe again. On our end, I think it's a matter of just having not exactly realized what NEMSQA was doing and what, how we could more utilize it. I was aware of the NEMSQA benchmarks as, the 11 benchmarks that are available on the dashboard on the NEMSIS site, but not with the rest of it. So there, maybe, at least for me, there was an education piece of it. I'll be scouring through the website now, but prior to that, I was not as aware of it. So it's one piece of input there.
No, thank you.
Well, maybe this is a topic we can delve into in a little bit more detail. It is a long call. Maybe folks are a little bit tired, but yeah, we could bring this back and maybe refamiliarize folks with the API and see what we can do to kind of improve uptake. It's a great opportunity for us to kind of standardize an approach to performance kind of assessment. So it's something worth the time. Thanks, Sheree.
All right, we are just about to time. Just a reminder that we have a public training coming up July 6th. This will be specific to vendor tools and resources. If any of the vendors on the call do not have a vendor NEMSIS account to be able to access the vendor dashboard, let us know, and we'll make sure that you've got that account and the permissions to access the information for your product on the vendor dashboard. That training is July 6th. Even though it's specific to vendors, anyone's welcome to attend. And then we have boot camp coming up July 13th. That is specific to states and state offices of EMS who are involved in implementing 3.5. So that one's a limited audience. And then annual meeting, August 3rd through 5th. Our next V3 call will be June 23rd, same time, same place. And We look forward to seeing you all back here. Please let us know if there are items that you would like added to the agenda so that we can work that in and talk about them. You guys are really great about contributing and having those good conversations. So we appreciate your time this morning. Thanks, everyone.